Welcome back to the Deep Dive, where we tear into the thickest stack of sources, extracting the most vital nuggets of knowledge so you can walk away not just informed, but equipped with the context necessary to truly understand global crises.
Today, we are tackling one of the most complex, long-running, and just devastating tragedies facing the United States, the drug overdose epidemic.
And when we look at the raw scale of this, I mean, the language almost fails you.
It really does.
Yeah.
In 2023, the total number of U.S. drug overdose deaths exceeded 105,000.
105,000 people.
And to put that catastrophic loss into a, sobering historical perspective, that single-year death toll is greater than all U.S. military fatalities across the Vietnam, Iraq, and Afghanistan wars.
Combined.
It really defines a national structural disaster that has been evolving now for a quarter of a century.
It is an unimaginable loss of life, but, and this is why we're doing this deep dive right now, the sources we reviewed contain a very fragile yet promising signal.
That's right. The provisional data for 2024 showed a significant decrease.
Yeah, about 27%.
It dropped the death toll back toward 80,000 deaths.
Now let's be absolutely clear. 80,000 is still a tragedy. That's over 200 preventable deaths every single day.
It's an ongoing nightmare. But that drop, that major dip, it proves that something is finally starting to shift in the right direction.
It suggests that some of these new policies, this new framework, is finally starting to work on a massive scale.
It does. The shift toward public health interventions and away from, purely punitive measures, it's finally beginning to show its efficacy.
Okay, so that really sets our mission for today. We are moving entirely past the tired war on drugs rhetoric.
And the simple narrative of bad guys selling drugs.
Exactly. We need to follow the data to uncover the fundamental structural causes that created this crisis. Our core questions aren't just who is selling the drugs today, but crucially, why does the demand exist?
And perhaps more critically, how did the supply become so incredibly lethal, seemingly overnight, turning a public health problem into a mass mortality event?
And the sources are, they're unified on this point. The origin story of this current crisis is a profound paradox.
It really is. It did not start on the street corner. It was born within the legitimate medical system.
Right. And so the policy framework has to shift. We have to address the user's vulnerability while also tackling this hyper-toxic supply chain and, the systemic failures that started it all.
Exactly.
So let's unpack this, starting with the very foundation of how the U.S. understood and, frankly, misunderstood addiction for almost half a century.
We have to begin with the gateway theory. This was the orthodoxy, right? Widely accepted, dating back to sociologist Denise Candel's research in the mid-70s.
And for years, for decades, this was the framework every educator, parent, and politician operated under.
It absolutely was.
So walk us through that old orthodoxy. How did the gateway theory actually describe the process of addiction?
Well, it proposed this fixed, sequential, almost inevitable progression.
Like a ladder.
Yeah. Exactly like a ladder. It suggested young people begin with legal substances, alcohol, tobacco, and then they must move sequentially to soft drugs, specifically marijuana.
Okay.
And then from there, they would progress to hard drugs like heroin or cocaine. The entire logic rested on that sequence. One step necessarily led to the next.
And this theory wasn't just descriptive, right? It was prescriptive. It became the backbone of massive federally funded policy initiatives.
Precisely. This sequential belief was the core logic for huge prohibitionist education programs.
DARE comes to mind.
DARE is the most famous example. The whole philosophy was if you could just block the use of the initial gate substance marijuana, you could prevent the progression to opioids or cocaine.
So the focus was all on blocking that one step, that one perceived biological march toward harder drugs.
That was the idea. But modern neuroscience and epidemiology they've rendered this theory almost entirely obsolete.
So if we look at the scientific critique, what was the fundamental, the critical error that policymakers made when they adopted this theory?
The error was a basic logical flaw, confusing correlation with causation.
Okay, break that down.
Yes. It's true that many users happen to try drugs in that order. But that correlation, that observed sequence, doesn't mean that using one drug causes the biological or psychological need for the next.
It's just an observation of a pattern.
Right. And the sources cite this massive 17-country comparative study by Degenhardt, which essentially just dismantled that causal link.
So how did that study refute the idea of a fixed internal gateway?
Well, it showed that the sequence of drug use is overwhelmingly driven not by internal biology, but by external factors,
Like what?
primarily availability and the local social environment. In some places they studied, where heroin was culturally easier to get or cheaper than marijuana, the sequence was sometimes reversed or skipped entirely.
And the gateway theory can't explain that.
It can't. It can't explain why many users jump steps or, more importantly, why the vast majority of people who try marijuana never progress to harder substances. It just fails to explain the true neurobiological why for those who do progress.
So, if the decades-old gateway theory is out, if blocking one specific drug isn't the magic bullet, what's the modern scientific paradigm that NIDA, the National Institute on Drug Abuse, has adopted?
They've pivoted to the Common Liability to Addiction model, or CLA. This is the modern framework, and it shifts the focus entirely from the substance itself to the individual's inherent vulnerability.
Okay, let's define CLA clearly. If it's not the drug creating the demand, what is this liability we're talking about?
CLA states that addiction is rooted in a fundamental, shared underlying liability that is consistent across all substance use disorders: alcohol, opioids, stimulants, you name it.
So it's not about a specific drug, it's about a general vulnerability to the process of addiction itself.
Exactly. The issue isn't which drug you try first. The issue is that you were already wired, socially, emotionally, or genetically, to be highly vulnerable to any powerful substance that offers a potent form of self-medication or reward.
So instead of a mandatory linear path, it's more like a deep well of vulnerability that any substance can activate.
That's a great way to put it.
And what are the main forces that drive this underlying liability?
They fall into two main categories. First, you have the biogenetic factors.
Okay.
This includes measurable genetic predispositions, specifically relating to the brain's dopamine reward circuit and, variations in genes that govern impulse control.
Can you give us an analogy for that?
Sure. Think of addiction vulnerability like a heart condition. You might be genetically wired for high blood pressure, right? But it's the environmental factors, diet, stress, lack of exercise, that actually trigger the clinical crisis later on.
That makes sense.
It's the same here. It's not that the first drug made the person addicted. They already had the genetic wiring to become addicted to any powerful available substance.
The environment acts as the trigger on a pre-existing genetic fuse. So what about that second category, the environmental forces?
Those are the psychosocial factors. These are the profound external causes. We're talking about adverse childhood experiences, or ACEs.
Things like neglect, abuse, household dysfunction.
Exactly. We also include chronic poverty, generational despair, unresolved trauma, peer influence. These factors create immense psychological burdens, driving people to seek substances not for fun, but as desperate coping mechanisms.
The goal is just a rapid, temporary emotional escape, regardless of the chemical.
Precisely. Which is why you often see concurrent use, not sequential use.
This complete pivot in understanding from the drug to the underlying vulnerability, that has radical implications for policy, doesn't it?
It absolutely does. The CLA model explains the extremely high rates of comorbidity. Addiction rarely travels alone.
You mean it's often paired with other mental illnesses?
Very frequently. Chronic depression, severe anxiety disorders, untreated ADHD. So this forces a policy shift. The solution can't just be policing drug markets.
You have to ask, why is this person vulnerable?
Exactly. You have to make comprehensive mental health support and trauma-informed care essential parts of any long-term demand reduction strategy.
That brings us perfectly to the historical structural collapse that created the modern epidemic. The sources are so clear on this. This crisis did not start with users looking for a high.
No, it started with a systemic breakdown, and it's critical to grasp that. This historical phase is often called the iatrogenic epidemic,
Which comes from the Greek for
brought forth by the healer.
it was caused by the very system designed to protect health, starting within the medical system and evolving in three distinct interconnected waves.
So let's start with wave one.
Yeah.
The iatrogenic epidemic, spanning roughly 1999 to 2010. What role did the pharmaceutical industry play here?
This period was really defined by corporate malfeasance and incredibly aggressive, misleading marketing. Companies, most notoriously Purdue Pharma, drove this campaign to revolutionize how pain was treated.
The pain is the fifth vital sign campaign.
That's the one. They pressured doctors and hospitals to treat pain aggressively with potent opioids. And they backed this with false assurances, using dubious data to claim their drugs, like OxyContin, carried an addiction risk of less than 1%. Less than 1%. And what was the quantifiable, devastating impact of normalizing these incredibly potent drugs?
The hard data just shows a complete systemic failure. Opioid overdose deaths quadrupled, between 1999 and 2010.
Quadruple.
And that's directly proportional to the explosive increase in prescription rates. But here is the most stunning statistic, the one that completely reverses the historical pattern of addiction.
Okay.
75% of people who began misusing opioids in the 2000s got their first drug through a doctor's prescription.
Wow. 75%. That's a staggering indictment.
It is. The medical system became the massive, legal, and initially unsuspecting gateway for addiction.
So 3 out of every 4 people who entered this crisis entered it completely legally, through a prescription pad, often after a routine injury or surgery.
That's correct.
How could the medical community, under the influence of these pharma companies, justify keeping those prescription rates so high, even when addiction was clearly escalating?
It was complex. It was rooted in regulatory capture and a total lack of proper monitoring. Purdue-sponsored pain organizations leveraged key opinion leaders in medicine. They basically shaped the educational narrative.
And there was no system to track prescriptions.
No centralized system. A patient could go to 3 different doctors, get 3 opioid prescriptions, and no one would have a unified view of that risk. The system was just engineered for blind spots.
And that failure to stop overprescribing created this giant population that was physically dependent or addicted, which leads us directly into wave 2 from 2010 to around 2013, the balloon effect.
Right, and what triggered the market shift in this period was, finally, policy backlash.
People couldn't ignore it anymore.
Exactly. States began clamping down on pill mills, and pharma companies reformulated their drugs, putting in anti-abuse technology to make them harder to crush or inject.
So on the surface, that sounds like a good thing.
It was designed to be. But for the millions of people who were already physically dependent, this restriction did the exact opposite of what policymakers intended.
It proved the iron law of prohibition in real time.
Perfectly. Restricting the supply doesn't eliminate the demand. It just forces the market to provide alternatives that are cheaper, more available, and almost always more dangerous.
And as prescription opioids became scarce and expensive, these addicted users migrated.
They migrated to cheaper illicit options, primarily heroin.
Why heroin specifically?
It offered a similar effect for a fraction of the cost, and often a stronger high, because it lacked the time release mechanism of the old pills. The data shows that a pretty significant subset, about 4 to 6% of people misusing prescription opioids, transitioned to heroin within 5 years.
4 to 6% might sound small, but when you're talking about a population of millions of misusers created in wave 1,
You're talking about hundreds of thousands of new heroin users. It was a massive influx into the illicit market.
and we can quantify that spillover.
We can. A staggering 80% of current heroin users surveyed had a prior history of misusing prescription pain relievers.
So wave 2 wasn't a new crisis. It was just the untreated addiction from wave 1 spilling out of the pharmacy and onto the street.
Where the drugs were less regulated and deadlier, which sets the stage for the current hyperlethal phase, wave 3, starting around 2013, the toxic supply shock.
This is where fentanyl enters the chat and just fundamentally transforms the mortality rate.
Fentanyl turned the drug landscape into a true mass mortality event. Illicitly manufactured fentanyl, or IMF, is terrifyingly potent.
How potent are we talking?
It's 50 times stronger than heroin and 100 times stronger than morphine. And crucially, a single lethal dose is only about 2 milligrams.
2 milligrams? What does that even look like?
It's an amount that's almost impossible to see with the naked eye. It could fit on the tip of a pencil.
That escalation from a prescription pad to a 2 milligram lethal dose, it's impossibly fast. What was the core economic driver that made fentanyl dominate the market so quickly?
It was a revolution in the economics of illicit drugs. Heroin relies on agriculture farming poppies. It's resource-intensive, seasonal, risky. Fentanyl, on the other hand, can be synthesized chemically in a lab quickly, cheaply, and year-round. It bypasses all that risk.
And because it's so potent, it's easier to smuggle.
Incredibly easy. You only need a tiny volume to produce thousands of doses, so it's wildly profitable and much harder to detect at the border.
And the mortality data reflects that complete market dominance.
It does. Synthetic opioids, which is overwhelmingly fentanyl, were responsible for roughly 69% of all drug overdose deaths in 2023.
69%.
And this wave is defined by intentional deception, the proliferation of deadly counterfeit pills.
So they're pressed to look exactly like legitimate medications.
Exactly, like M30 oxycodone, Xanax bars, Adderall tablets. But they contain lethal, often unevenly distributed amounts of fentanyl.
So if we look at this structural collapse as a whole, wave one was corporate greed and overprescribing, creating a massive dependent population.
Wave 2 was policy restriction forcing that demand into the illicit market.
And wave three is hyperlethal, synthetic supply meeting that desperate existing demand. It's a crisis that has continuously evolved based on structural factors, not just individual choice.
That's the key takeaway.
Now we have to talk about that demand base, specifically how people actually enter the system versus how the public perceives that entry.
Right. Because the perception, driven by decades of policing narratives, is that addiction begins with a shady deal on a street corner.
But the data on initial misuse tells a radically different story.
The National Survey on Drug Use and Health, or NSDUH data for 2024, it just fundamentally challenges that stereotype. It shows that in the initial phase of prescription drug misuse, the criminal market is a distant minority source.
Okay, so let's look at that sourcing data. Where do people who misuse prescription drugs actually get their first pills?
The NSDUH data reveals this almost unbelievable paradox. An astounding 86% of misusers get their drugs from non-criminal sources.
86%, how does that break down?
It's almost an even split. About 43% get them from friends or relatives.
So, taken from the medicine cabinet, bought casually, or just given away?
Correct. And a nearly equal 44% obtain them legitimately via healthcare providers, whether through a single prescription or, the historical problem of doctor shopping.
Wait, so if you add that up, 86% of the initial supply came from their own medicine cabinet, a friend's cabinet, or their doctor. That leaves a tiny sliver for the traditional drug dealer in that initiation phase.
It does. Only 7.6% of misusers reported getting their pills from a drug dealer or a stranger during that initial pivotal phase.
That is the crucial paradox we have to address. The entrance to addiction is overwhelmingly domestic, the family medicine cabinet or the doctor's office.
But the exit, the phase that causes mass mortality, is cartel-driven toxic fentanyl.
So if the front door is domestic, does that mean our traditional policing and interdiction efforts are focused on the wrong target? On the back door?
It suggests they're necessary, but completely insufficient as a primary prevention strategy. Since the main source of initial misuse is domestic and medical, the most high-impact prevention strategies have to be clinical and community-focused.
Things like tightening the PDMP database, improving clinical practices, and massive community campaigns for safe drug disposal.
Exactly. Those are the high-leverage moves that seal that front door where the epidemic began.
But once that person is addicted, they are forced into this market controlled by highly sophisticated international actors. Let's trace the modern, globalized fentanyl supply chain that the DEA has identified.
It's a very sophisticated three-part chemical logistics chain. It begins in China.
China is the source of the precursor chemicals.
That's right. Despite increased pressure, China remains the primary global source of the building blocks needed to make fentanyl. These chemicals are often exported under the radar, sometimes mislabeled, and they're bound almost exclusively from Mexico.
And Mexico acts as the massive production hub.
Precisely. This manufacturing is dominated by powerful organized crime groups, the Sinaloa and Jalisco New Generation Cartels, or CJNG.
They import the Chinese precursors, synthesize the fentanyl, and then what?
They're highly specialized. They focus heavily on pressing it into those very convincing counterfeit pills. The M30s that mimic oxycodone, the fake Xanax, this just maximizes their profit and their market reach.
And how does that finished, highly lethal product then reach the U.S. consumer?
The distribution phase is increasingly digital. This is the cartel's competitive edge. The finished product is smuggled across the border and then trafficked via social media.
Snapchat, TikTok,
encrypted messaging apps. This shifts distribution away from risky face-to-face street sales and toward direct consumer methods. The ephemeral nature of these apps makes law enforcement tracking incredibly difficult.
And that digital distribution has lowered the bar for fatal exposure, creating this terrifying new danger summarized by the phrase, "one pill can kill."
This trend is skipping the old gateway entirely. It's creating a new mortality pathway. Young people especially are accessing these pills and entering the opioid stream directly.
They think they're getting a real Adderall to study or a Xanax for anxiety.
Exactly. But instead, they're ingesting a single counterfeit pill containing a potentially lethal dose of fentanyl with no tolerance and no knowledge of the risk.
And the risk profile here, based on the DEA's analysis, is genuinely terrifying.
It is. DEA analysis of seized counterfeit pills found that a chilling 7 out of every 10 seized counterfeit pills contain a lethal dose of fentanyl.
7 out of 10.
That level of deception and inconsistency in the illicit supply chain is the core mechanism behind the staggering mortality rates we've seen in Wave 3.
Beyond the catastrophic human toll, this crisis represents a genuine existential threat to the U.S. economy. Let's try to quantify the sheer mind-bending scale of the financial damage this is imposing.
The opioid crisis is no longer just a healthcare or criminal justice problem. It's a full-blown macroeconomic catastrophe. The 2023 estimated total economic loss is just staggering.
What's the number?
$2.71 trillion.
Trillion, with a T.
That figure alone represents about 9.7% of the entire U.S. gross domestic product. That is the cost of a war waged against its own citizens.
Nearly 10% of the entire U.S. economy. That number is so abstract. Can you ground it for us? How does that 2.71 trillion figure break down?
Well, the majority of the loss is tied to the irreplaceable value of human life and quality of life. The largest component, at 1.1 trillion, is the loss of statistical life, or VSL, from premature overdose deaths.
Explain VSL for us. It sounds cold, but it's a necessary tool for policymakers, right?
Absolutely. VSL is a standard metric used to value safety improvements. It's not placing a value on a specific person. It's measuring society's willingness to pay to reduce the risk of death, based on things like lifetime earnings potential. When over 100,000 productive citizens die prematurely, the VSL loss is enormous.
What about the costs for the millions who survive but live with opioid use disorder?
That is the second major component, loss of quality of life, valued at 1.34 trillion. This is based on data that estimates OUD patients live at only about 62% of full, healthy life capacity.
And then you have the direct, measurable costs.
Right. About $277 billion, covering things like the massive healthcare burden on emergency rooms, lost productivity, and criminal justice costs. But really, the non-monetary human costs, the loss of potential, are the real economic drivers.
This cost structure highlights the almost absurd absurdity of underfunding treatment. When you look at the social cost per patient, treatment is undeniably the best economic investment you can make.
It is the ultimate business case for public health intervention. Our sources note that in some highly affected areas like Washington, D.C., the annual social cost generated per single person with OUD can exceed $2.4 million.
$2.4 million for one person for 1 year.
Yes. When you juxtapose that against the cost of comprehensive, year-long treatment, which is often just tens of thousands of dollars, the argument closes itself. Investing in recovery is the most fiscally responsible action a government can take.
While the dollar figures are almost incomprehensible, the human devastation isn't distributed equally. Let's shift to the demographic and geographic inequality highlighted in the 2023 data. Who is suffering the most?
The disparities are stark, and they reveal these deep systemic failures. The population group with the highest mortality rate is American Indian and Alaska Natives at 65 per 100,000 people.
And how does that compare to other groups?
It is an immense burden.
Right.
It's 12 times higher than the rate for Asian Americans. This disparity is often connected back to historical factors, generational trauma, systemic poverty, and severely under-resourced healthcare in tribal areas. It ties directly back to those psychosocial factors in the CLA model.
And what do the recent trends tell us about access to effective prevention and treatment? Is the gap closing?
No, the trends show a widening gap. Between 2022 and 2023, while non-Hispanic white populations saw a substantial 7% decrease in mortality.
It's good news.
It is. But Black populations saw a concerning 3% increase. This illustrates a fundamental breakdown in equity. Effective strategies, particularly access to medication, are clearly failing to reach all communities equally.
And geographically, while Appalachia is the historical epicenter, the nature of the crisis is evolving across the country.
Appalachian states are still the hotspots. West Virginia leads the nation with a staggering mortality rate of 90.9 per 100,000.
Wow.
It's driven by decades of industrial decline and that historical overprescribing. But we see a worrying trend in several western states, Alaska, Montana, and Nevada, where overdose deaths are still rising, defying the national decline.
And why is that?
It's largely because fentanyl has combined lethally with existing entrenched methamphetamine markets, creating a different kind of regional crisis that requires interventions aimed at stimulant users too.
This complexity brings us to the pathology of the modern threat, polysubstance use. Why are most overdose deaths today not from a single drug, but from a combination?
Polysubstance use has become the defining characteristic of the Wave 3 mortality event, and it's lethal for two main reasons: intentional mixing and unintentional contamination.
Let's start with intentional mixing. What is the goal when users combine powerful depressants and stimulants?
Users are trying to achieve a specific but very precarious pharmacological balance. The classic mix is a speedball, mixing an opioid downer like fentanyl with a stimulant upper like cocaine.
The goal being to maximize euphoria while minimizing the negative side effects of each.
Exactly. But it introduces these complex, rapid shifts in vital signs that the body just can't handle.
And the far more common and lethal scenario is that unintentional contamination linked directly back to the fentanyl supply shock.
Correct. This is a profit-driven contamination strategy. Suppliers secretly and carelessly mix cheap fentanyl into other drugs, cocaine, meth, counterfeit pills, to increase potency and drive repeat sales, often without telling the user.
So the user takes their typical dose of, say, meth, but is unknowingly ingesting a lethal amount of fentanyl.
And they have no opioid tolerance, so it results in sudden respiratory arrest.
And the sources detail specific fatal combinations where the synergy is just exponential.
It's deadly. Combining opioids with benzodiazepines like Xanax creates a massive compounded risk of respiratory arrest. But the combination of opioids and stimulants is particularly insidious
Why?
because it creates a masking effect. The stimulant high masks the depressive respiratory slowing effects of the opioid. The user feels awake and high, not realizing their breathing is dangerously suppressed until they crash, which is often too late.
And finally, the newest and most challenging combination for first responders, fentanyl mixed with xylazine.
Xylazine, or tranq, is a non-opioid animal tranquilizer, and its presence is exploding in the illicit supply. When mixed with fentanyl, it causes respiratory failure that is often partially or completely unresponsive to naloxone.
Because it's not an opioid.
Exactly. Naloxone can't reverse its effects. And furthermore, xylazine causes these severe, necrotizing skin lesions, deep, festering wounds that require complex care and often overwhelm local healthcare systems. It just signifies the ongoing, terrifying evolution of the toxic supply chain.
We've established that the problem is rooted in corporate failure, structural inequality, a failed policy theory, and a hyper-toxic supply chain. So the solution has to be equally comprehensive and integrated. Let's start with strategy A, radical harm reduction. We have to change the primary metric of success.
We must shift the policy goal from the idealistic, unachievable fantasy of a drug-free society to the practical, compassionate, and essential goal of a society without preventable death.
Harm reduction doesn't eliminate use, but it saves the life now.
It creates the necessary window for recovery later.
And the data proves this works, particularly with naloxone.
Naloxone, or Narcan, universal access, is paramount. Its expanded availability is directly credited as a major factor in that 2024 mortality decrease we saw. It has to be treated like an AED, a defibrillator.
Mandated in public spaces, highly publicized, easily accessible.
Absolutely. It is the single most effective tool for immediate life-saving.
What about preventing those accidental fentanyl exposures for people who aren't using opioids intentionally?
That's where drug checking kits become essential. Providing low-cost fentanyl test strips to users is a high-impact, low-cost strategy. It prevents deaths from accidental ingestion of counterfeit pills by just giving users the knowledge they need to avoid a deadly dose.
It respects their choice while prioritizing their survival.
Exactly.
And then there's the controversial but internationally effective approach of overdose prevention centers, or OPCs.
OPCs are facilities where individuals can consume pre-obtained drugs safely under medical supervision. And while they are politically challenging, their purpose isn't to encourage use.
It's to serve as a crucial entry point to the treatment system.
That's the key. Staff can intervene immediately, and crucially, they build the trust necessary to link users with long-term treatment, housing, and social support. International studies show they drastically reduce fatal overdoses.
Moving to strategy B, systemic accountability and supply chain control. We have to address the entities that created these conditions in the first place.
This is about pharma justice. The sources highlight these landmark legal settlements, like the multi-billion-dollar agreement with Purdue Pharma. And these are not just fines.
Right, the money is dedicated.
It's dedicated. Yeah. It's channeled into state and local opioid relief funds, specifically to rebuild treatment infrastructure, buy naloxone, and establish prevention programs.
If the first wave was caused by these information black holes, how do we prevent that from ever happening again?
The key technological and regulatory fix is the Prescription Drug Monitoring Program, or PDMP database. This is a mandatory statewide electronic system designed to be the eyes and ears of the prescribing system.
So how does the PDMP actually operate to prevent harm in a clinical setting?
It tackles three primary threats. First, it stops doctor shopping patients getting duplicate high-dose prescriptions. Second, it flags dangerous co-prescribing, like opioids plus benzodiazepines.
Alerting providers to that exponential risk.
Exactly. And third, it tracks high MME or morphine milligram equivalent prescriptions, flagging providers when a patient is receiving excessively high doses. It turns a fragmented system into an informed one.
Finally, in terms of supply, the fentanyl supply chain is decentralized, digital, international. How do we apply pressure there?
We need smart interdiction that's focused on disrupting the entire ecosystem, not just chasing low-level dealers. We have to acknowledge how hard it is to police the dark web and crypto.
So the strategy has to prioritize international cooperation.
It has to. Intense diplomatic pressure on China to control precursor exports and working closely with Mexico to disrupt cartel production hubs. The goal is to degrade the ecosystem by following the money and the chemicals.
Let's turn to strategy C, the long-term solution. The recovery roadmap. If we save a life and reduce the supply, how do we rebuild that person's stability?
We have to first internalize that addiction is a chronic disease that requires long-term support, far beyond a quick detox. It's a biological and psychological disruption, not a failure of willpower.
And the most evidence-based medical treatment is MOD.
Yes, medication for opioid use disorder. We need to dramatically increase access to proven treatments like methadone and buprenorphine.
And policy has to focus on eliminating the barriers to that access.
Right. And given that the overdose risk is extremely high immediately after someone is released from prison, like 40 times higher mode must be mandated and provided within correctional facilities to bridge that dangerous transition.
The sources map out the long, complex journey of recovery, and it's not linear. What are the defined danger zones we need to understand?
The danger zones are defined by the brain's recovery timeline. After initial detox, there's often a dangerous pink cloud phase.
The pink cloud phase.
Yeah, about 15 to 45 days in, where the patient feels artificially great, euphoric, and overconfident. This often leads them to drop out of treatment and relapse.
And that's followed by the devastating wall phase.
Exactly, from about 45 to 120 days. It's marked by severe anhedonia, the inability to feel pleasure, and deep depression.
And why does that wall happen?
It happens because the brain's dopamine system is severely depleted, and the prefrontal cortex, the part for planning and executive function, is still rebuilding itself. The essential infrastructure here is psychological support to help them push through that wall of despair.
And this is where physical stability and community become paramount to breaking that cycle.
That's where recovery housing is absolutely critical infrastructure. These are structured, substance-free environments that provide stability, peer mentorship, and accountability.
And studies show that when MOUD is paired with recovery housing, the outcomes are much better.
The relapse rates drop significantly, and employment success rates soar because the individual has regained stability and a network of support.
Ultimately, if we go all the way back to the common liability model, the ultimate, most cost-effective demand reduction strategy isn't about drugs at all, is it?
No, it is about investing in the social protective factors. The CLA model teaches us that vulnerability is driven by trauma, despair, and lack of opportunity.
So the long-term solution is macroeconomic and social.
It has to be. Poverty reduction, job training, universal youth mental health services. We have to invest in community resilience and stability to fundamentally counter that underlying liability.
This deep dive has revealed that the U.S. drug crisis is not a simple morality tale or a police procedural. It is a profound failure of structure. Let's quickly recap that complex narrative.
The crisis is a continuous evolutionary structural collapse. Corporate greed opened the door in Wave 1. Failed prohibitionist policy drove users to the illicit market in Wave 2.
And now, cartel-manufactured fentanyl provides the lethal final blow in Wave 3, dominating the market through its sheer potency and profitability.
The major paradox remains our policy challenge. The entrance to addiction is overwhelmingly domestic. Your doctor, your family's medicine cabinet, that's 86% of initial misuse.
But the exit, death, is overwhelmingly lethal and criminal. The toxic fentanyl supply, accounting for nearly 70% of all fatalities.
And that paradox is why the promising 2024 decline is so important. It shows that scientific, public health-based strategies, expanded naloxone access, MOUD use, better prescription tracking, they actually work to save lives now.
The path forward requires synchronized integrated policy. We have to coordinate smart international supply interdiction with a massive localized surge in harm reduction, treatment, and crucially long-term social support like recovery housing.
This deep dive really reveals that the United States must fundamentally shift its national aspiration. We have to abandon the unachievable, outdated ideal of a drug-free society.
And move toward the compassionate, scientifically sound, practical, and economically sensible reality of a treatable society.
Exactly. The goal isn't to eliminate human choice. It's to eliminate preventable death and rebuild the lives and communities that have been shattered by this long-running structural disaster.